Ding.
Right.
We're recording. We're in business. All right. So go ahead. So what were you going to say about your doctor's papers or your father's?
That's great. Well, first of all, we're very happy to join you, and we really appreciate the invitation to first of all, to see Chris Ebert-Santos, with whom we have established a relationship related to hypoxia, chronic hypoxia in this case, but also as a human relationship, because we are aligned in some concepts. Here, Natalia, my daughter, Natalia Zubieta, nice to meet you, Michael. Here, she's an MD.
Yes.
And I understand you're doing a PA, right? Physician's assistant?
Correct. That's correct. Yeah.
That's great. But anyway, and this talk is regarding actually the paper we recently published with Natalia,
That's
which is called Acute Mountain Sickness, High Altitude Pulmonary Edema, High Altitude Cerebral Edema, a view from the Highlanders, I think.
Or high Andes or something like that. Yes.
Right, a view from the high Andes.
Right.
And it's very interesting, and I'm so happy that this has interested you, Michael, because we had to finally put on the table our point of view regarding chronic hypoxia, the effect of acute hypoxia to the newcomers, based on 50 years, and I'm not kidding you, it's 50 years of experience that our institute, the High Altitude Pulmonary Pathology Institute, has been created by my father in 1970, okay? And actually it's on the 9th of July, so I always remember it when the 4th of July comes up, that we have another anniversary coming.
Yeah.
Right. So, by the way, I really have enjoyed your questions, Michael. That was quite impressive.
Yeah.
Come in.
We have a couple more students coming in to join.
Oh, come in. Welcome.
Yes.
That's
It
wonderful.
would be nice to see you. You're hiding behind.
Yeah,
me.
please come on the screen. Come on the screen. We can't see you. Please.
Hello.
Oh, that's good. Wonderful.
Hello. How are you?
Okay, this is Natalia. She's an MD. I am also an MD. And I was telling Michael, do we look like sick people because we live at 3,500 meters of altitude? And one of the fundamental concepts that we spoke of in our paper called extended longevity at high altitude, Michael, is that high altitude is like exercise for sea level people. In other words, hypoxia becomes a marvelous stimulus for our bodies. We have to adapt. And as you know, we in our paper, we have spoken about the genetic adaptation, but also the physiological adaptation. In another paper that I'm writing, I say, yeah, the genetic adaptation is many generations, of course, and maybe over millions of years or 100,000 or whatever. But the physiologic adaptation is within one's lifetime. And actually, it can be shorter. It's within weeks for certain factors. And I really have enjoyed the questions you wrote down, which makes this interview very interesting for us, because sometimes they give us interviews and you know, press people really don't know much. So it's kind of, yeah, we have to go to basics. But with you, those questions were really nice. But we can understand that you are learning so much from Chris Ebert, that it's fantastic.
Absolutely. So shall we start?
Please
Please.
go ahead.
All right. So Dr. Zubieta, why don't you tell us about yourself? You know, why Hypoxia? Why pulmonology? What inspired you?
Well, my father was the great inspiration. I was born, Michael, in the city of La Paz at 3,510 meters precisely. In fact, I was born at home because my father was a physician and he preferred to deliver us. And we are 4 children and we all were delivered at home. And then that home became the clinic. And that was in 1970. And last year we have turned 50 years old. And in this clinic, he was our mentor, our professor. I grew up. Actually, I was 15 when the clinic was started. I am now currently 65. And one of the things that this stimulus was my father. Obviously, he knew about medicine. My mother was a nutritionist. My older sister was an MD, is an MD. Then I am the next MD. Then comes Nancy, who was a biotechnologist, my other sister, and my other brother, who's also an MD. And so we were all just put into this because this is what we knew best what to do. And he created the first high altitude clinic in the world. He did it with a visionary idea because at the time in 1970, nobody thought about putting a clinic at that altitude. And plus the city of La Paz and El Alto is right now currently composed of over 2 million inhabitants living at this altitude. And so at that time, probably there must have been maybe 250,000 people. I don't know, I'll have to check. But anyway, he thought it was important to put a specialized clinic. And sometimes people, even when he opened the clinic, they said, what are you doing? There's no need for a high altitude clinic. He said, oh, absolutely, there is need for a high altitude clinic. And they said, oh, you're going to probably put a chamber in there. And yes, we did put a chamber, and we have we've had two high altitude hypoxic adaptation chambers.
Yeah. That sounds good. Let's see here.
We go on.
Oh, it sounds like, I mean, I think you pretty much answered my next question already, but so you've pretty much been living at high altitude your entire life then, it looks like.
Yes.
Yeah.
Yes, that's a fact. Let me tell you, when you asked me the question, I made a calculation, and actually I've lived 57 years here at high altitude. My father died at 90 years of age. He lived here in La Paz. He was out of the country when he was 2 years a visiting professor at Tulane Medical School for a couple of years, and then spent 1 year in Mexico at the Cardiology Institute. So he lived 87 years at high altitude, mostly, let's say 86 with some traveling or whatever,
Yes.
but 86 years at high altitude. A very healthy man, took no medication, and he lived to be 90.
Yeah.
Yeah.
And
My mother,
can I say something?
yes, please.
Okay, so I would love to say that actually, you know, one thing that I think it's important to take in count is that my grandfather and my grandmother, all of them, they were all Spanish descendants.
Oh.
So we are Andeans who are not a native, we would say, no? And when there's nothing wrong with being a native or not, but it's just that if we're talking about adaptation, we would be the non-adapted kind, because literally we have almost no blood in the family coming from strictly
But we do
natives,
have
no?
some. We do have
No,
some.
for sure.
right.
But it's what I mean to say is that we would be in the same risk as you would be if you would come, pretty much.
How many generations are you talking about now at altitude?
Yeah.
That's right.
How many generations at altitude are you talking about now?
Oh,
That must be maybe 5, something
yeah,
like that.
3 to 5. My mother's grandfather was from Spain, directly from Spain. So that's 4 generations, 2, 3, 4 years generations. And let me tell you that my grandmother, my mother's mother, who was the daughter of this Spaniard that came to live here in Bolivia, she lived to be 99. Her sister lived to be 100, and her other sister 98. So they all were definitely descendants from Spaniards and lived that long here in the city of La Paz.
What is the distribution, would you say, in the La Paz El Alto area of indigenous versus Spanish ethnicity?
Well, we've all mixed up with the time. We have a lot of mixture,
Yeah.
where mostly everybody has a good degree of Spaniard blood, but we do have some indigenous, purely indigenous people. And I would say the percentage, what do you say, Natalia? That's difficult. We don't know.
It's very hard to say, but maybe it would be about half, I would say.
About half
like
would
maybe,
be indigenous, and
yeah,
the other half are mostly mestizo, not
yeah,
purely
and
Right.
mestizo.
yeah, exactly, because we're mostly mestizos. Like I tell you, specifically in my family, because we know who came to Bolivia, we know that there was maybe very little like mixture, but in the whole of the population, it's very hard to tell how pure you are, you know, because people get mixed up. So,
But and
so
among
that,
indigenous, there's the lowland indigenous and the highland indigenous. How much do they
yeah.
mix? Do they mix and intermarry?
I think they do, but it's probably a little bit less due to culture factors, because basically there are several ethnicities. We have up to 36 ethnic groups in the whole of Bolivia, and we have all kinds of ecological systems. So we have the Andean regions, then we have the valleys, and then we have the lowlands that are composed both by some sort of dry lands that are sort of like a savanna in a way. In the south, you even have dry areas where you can have sort of like desert areas, but then you also have the Amazon, which is completely wild. So we have all kinds of different ecological levels, and people living in different towns have other cultures, other beliefs, and so mostly people get mixed up between or among the people who are living in the same sort of plateau, I would say, you know. So if they are from the highlands, they could mix up, but they are kind of from the same culture. Then you have people from the lowlands, because everything is different. You know, you would have people who lived with bananas, you know.
And no
And
clothes, hardly any clothes.
yeah, and then you will have people who live with llamas, and it's completely different, you know.
Right.
So their cultures, I think, would be the biggest cultural issue, and because also they have their own languages and everything, so they probably won't be able to understand each other.
But I can see where the question goes, Chris, and it's an important and interesting question.
Mhm.
You see, the people that are from the lowlands, from the Amazon land, and from Santa Cruz, for instance,
Mhm.
they have they have acute mountain sickness when they come to high altitude. So they're not very fond of coming to high altitude.
Yeah,
And obviously, but when they come and they surpass the time, the adaptation time, which is according to our work, the hematologic adaptation time, which takes, you see, you have a couple of days that are the where you can have the acute mountain sickness or a high altitude pulmonary or high altitude cerebral edema, and can extend a few more days maybe. But in general, after that goes away, you have a subacute high altitude disease, which means you are limited to do exercise. Your headache can go away, the main cardinal symptom of acute mountain sickness, but you may be short of breath going up the stairs. So once you are achieve.
Oh, yeah, I'm still short of breath when I go upstairs. Yeah.
Right.
Yeah.
Oh yeah, but you were here, I guess, a week, right? That
Yeah.
was what it was, right?
yeah, yeah.
So, but if you remain with us 40 days, Chris, if you remain with us 40
No,
days.
here, I'm still short of breath going up.
Oh,
Even though I
really?
climb a mountain, but I'm still short of breath going upstairs.
Oh, okay. That has to do with your red blood cells. But anyway, so we when we increase our red blood cells to our optimal level in about 40 days, you know, we adapt. And these people that come from the lowlands, from the Amazon, they adapt perfectly well. And then many of them stay and marry and live for all their lives here at high altitude.
Mm-hmm.
So obviously, when you go somewhere, do you enjoy the day after having a hangover from having drank half a bottle of whiskey? Nobody enjoys that, okay? So nobody enjoys acute mountain sickness. And many people say, no, I don't want to be, this is horrible. I don't like high altitude, and they want to leave. But we have had many people, you know, stay after, and when they surpass that, they are in a good adaptation.
And a lot of people even like to come live here, and they just leave their homeland because they find benefits in living up here, even in their health. So it's because it's a very dry environment. And for instance, for certain types of allergies and asthma and all those kinds of things, they feel very, very much in peace and very comfortable. So they actually prefer it. So it's a question of being healthy and and not having other diseases that could make you feel bad in this situation. No?
For instance, asthma for kids, I treat patients from the embassies and their children, when they are in their countries, are suffering from asthma crisis that are being hospitalized often. They're on medication, inhalers and all that. They come to La Paz and I mostly tell them, okay, lower your medication or drop it.
Yeah.
And they drop it and they're happy. They live here years and then they dread the moment they have to leave La Paz to go back to their country.
Yeah. Actually, in my practice, I never saw one asthma crisis, and I had
It's very rare. It's very rare here. In fact, you know, that's why I wrote that paper, because all those kids are being told they have asthma. They didn't respond to bronchodilators, you know, they weren't wheezing. And that's why I just described the resident high altitude pulmonary edema or heart.
correct.
Yeah.
Oh yeah,
And
that's
so,
right.
and so actually I went to do some practice in the lowlands in the Amazon because I wanted to compare what I was seeing. And out of the blue in the emergency room, we had some crisis and I was shocked because it was quite dramatic in regard or in you know, in comparison to what we see here. So
Yeah.
so that then I had to rush and like look for my books and see, okay, what we were
And you know,
supposed
Chris,
to do in these situations.
I asked the head of intensive care of the main hospital in La Paz. I asked him, how many cases have you treated of an asthma crisis in intensive care in your unit? He said, in 35 years, none. That's how it is, because we are at 3,500. That's a significant difference. Let's see, you are at 2,500. Is that right, Chris?
2,800, but a lot of our patients live at 3,000.
Yeah.
Right. Wow. Yeah. Okay. So can we go on to your next question?
Sure. Yeah. The next question was, so you're in your you had mentioned the two types of adaptation, genetic and physiologic, right?
Oh, I love that question. I love it.
Did my own research and I found that Tibetans, you know, they've had a few genetic alterations and they've even been, you know, been credited with having one of the most fastest phenotypically observed evolutions in human history.
Right.
Right. And so, are you familiar with anything of that same caliber in South American population?
Well, I can give you some clues, but obviously a lot needs to be done now.
I think, yeah.
I'm going to put three words that will be very interesting for you, and I'm sure Chris will appreciate it. It's called increased mitochondrial efficiency.
Right.
Okay, that's completely new. We are the ones that have talked about that because you see, every cell, every tissue, and every organelle within cells has to adapt to the new hypoxic condition at high altitude, okay? And what's interesting is that the concept that the Tibetans are better adapted to high altitude and the Andeans, for us, is a completely wrong concept, okay? Because that would mean we are not adapted to high altitude, that our organisms are not working well, that we are suffering here from high altitude, we're miserable. That's not true. My parents, I told you, my grandparents lived to 99. We have sports, we have it. So we are perfectly adapted to high altitude. Physiological adaptation and genetic adaptation, both, of course, but not in a different mechanism. There's only a difference of the mechanisms involved. But, you know, some people are fat, some people are thin. You're different, but that doesn't mean that you are, that doesn't mean many things. I mean, some people do a lot of sports, some people don't do sports, some people have abilities to view further and view shortened. That doesn't mean that you are better adapted. That means you're differently adapted, because if you don't have the same capability in one area, you have another capability in another area. And the end result has to be survival. And survival can be made through several mechanisms. many mechanisms. And the success is survival and reproduction at high altitude, which we carry out perfectly normal.
So in a way, if you think about
That's my daughter. We reproduce at high altitude.
Yes. But the thing is that if you think about it, what is normal? Because this situation, when you start to compare what's better and what's worse, you're basing it on an idea of what is better or what is normal, you know, and what goes further from that or not. So if you think historically, medicine and everything and all the knowledge that was regarded to, that was related to normality, to physiology, to pathology was described at sea level. So if we are different, we are assumed to be pathological, you see? And at high altitude, we have several different things, but that does not mean we are unhealthy. That's completely different. Now, one of the things that happens with this genetic adaptation concept has to do with the fact that they have discovered that the Tibetians, they seem to have a closer hematocrit and hemoglobin level or closer levels to those that are considered normal at sea level. So they assume that it might be because they are adapted genetically to stay as if they were at sea level. But if you think about it, there are several other things we have to take in account. For instance, there are different species. They did some research in mice and in rats, for instance. Oh, yeah. And they found out that they were completely different. Like the mice, they would keep a certain number of red blood cells that were similar to the ones at sea level, but they would have a higher ventilation capacity. Yeah, and so they are compensating in another way. It's not that they are staying exactly the same as at sea level. And we tend to compensate by hiring our red blood cells. Now, the thing with red blood cells is that they assume that if you have red blood cells, you will develop chronic mountain sickness. And they think that this is a progressive disease that will come throughout time at high altitudes. Like if the longer you stay at high altitude, you would develop this disease. That's what they have written in literature. For us, that is insane. That is insane because we know a lot of people. We've come from places that were from the lowlands. You never develop these things. I mean, the people who have these things, when you look at them and you make a checkup on them, you will find out that they always have some disease that is making them more hypoxic than the rest. So that might be a heart disease, that might be kidneys disease, that might be a carotid bodies disease, that might be a problem with the lungs. For instance, a lot of people who have chronic mountain sickness and they live in highlands in different parts in South America, they live in mining towns. And you know, when you mine, you are bound to be unhealthy very quickly in your life because you develop a lung disease and that's very deteriorating. So all these things add up. And so it's very hard that you would find somebody that would have an issue with the red blood cells that is not sick. You see, a normal person would not develop this randomly. That's very unusual. We have to write more about this, but like I tell you, it's very horrific to see that in the literature because no wonder people are scared of high altitudes.
That's right.
Great. So I think you had mentioned this before I started the recording. I just really wanted to get on tape, but could you tell us more about like people's cardiovascular health at high altitude and how does it compare to other South American high altitude per se? In terms of like life expectancy.
Oh yeah, it's very interesting. You mean with cardiovascular diseases?
Right. Yeah. Yeah.
Oh yeah. You see, any disease that produces hypoxia, any disease, whether it be a lung disease due to pulmonary shunts, due to uneven ventilation perfusion, due to diffusion alterations, that are all hypoxicating diseases. But on top of that, also hypoventilation syndromes, where the respiratory center, because the first three are related to the peripheral respiration, you know, at the lungs itself, those three, uneven ventilation, perfusion, shunts, and diffusion are at the lung tissue itself. But of course, the driving respiration also has a driving Boltzinger complex in the brain and stimulating a rhythm of breathing, a tidal volume, and a frequency. And so if you have an alteration in that area of your brain, obviously you can hypoventilate. And if you hypoventilate at sea level, for instance, like in Pickwick diseases, some overweight people, they can have some problems of an increase of red cells, for instance, because they are not ventilating their lungs properly and not getting enough arterial capillary oxygen exchange. And but at high altitude, if you have those same things and you are in a chronic hypoxia environment, you reduce the quantity of oxygen molecules exposed to your lung surface area. And so you obviously have to compensate it with something. And that is the beauty of red blood cells. I wrote a paper with my father and I don't remember who else it was, but it's related to the increase of red blood cells in hypoventilation at high altitude is an energy saving mechanisms. Because if you have a lung disease or a heart disease that is limiting the amount of oxygen you have in your organism, you would have to hyperventilate all the time and be tachycardic. But those two responses, the tachycardia and hyperventilation, are extremely costly in terms of energy. So your organism cannot handle it. In fact, that's what happens with high altitude, with acute mountain sickness, that you arrive and the first thing you do is you hyperventilate because you need to compensate. And you also have tachycardia and you try to improve your cardiac output, but that's kind of limited. The lungs are actually doing the fundamental role, but you cannot live at high altitude hyperventilating the way you do when you first arrive, because that would be so costly in energy.
So stressful.
So stressful, and it would wear you out, and you would be using up all your energy just to breathe. I mean, and so the organism looks for the least energy expenditure mechanism. And that's the beauty of an increased red blood cell count, because that allows for enough oxygen to be transported from the environment to the capillaries in tissues, and then from there through diffusion to the mitochondria. And when I was mentioning about the increased mitochondrial efficiency, is something we postulated that had to come. We had no proof of it, okay? But we understood this had to be happening. And it has been proved recently in a paper written by Christian Arias, it's just out, fresh out of the press in Frontiers, by Christian Arias, Joseph Vincent and Jorge Solis from the University of Canada. Of Laval University, I'm sorry, in Canada. And they have proved that evidently there is a better efficiency of mitochondria. And it had to be, because everything has to adapt. You have to adapt and you have to carry out normal life. You cannot lose adaptation, Michael. This is extremely important. Some people have talked about loss of adaptation at high altitude. My father was totally against that. He said, that's ridiculous. If you lose adaptation, you die. Life is about adapting. Every day of your life, you are adapting to the temperature, to the weather, to humidity. You never lose adaptation. If you lose your adaptation, you're doomed. That's it. It's over. Life is out. So he wrote a very interesting paragraph regarding this, and we obviously are strongly in agreement with him, because it's what we see.
So in a way, this challenges the normality parameters, because you have to understand that adaptation has to do with inevitable change. So if this change is not deleterious, then it's just absolutely necessary. It's like when you are exposed to doing exercise. So the first day you're going to go out and start jogging, you're going to be completely out of breath, you know, and you may not have that much of a difference, but keep doing it every day. And then one day you will not feel it anymore. And that will be because your cardiovascular efficiency will be much better. And so if you compare, you know that a heart and everything from a person who's under this chronic stress, that is actually also related to a higher energy and oxygen expense, that means these people have a different physiology. And this is exactly what happens to us in a different way, but it's a continuous stimulus that shapes the way you work. It takes time.
Right. Yeah. Even like from like a kinesiology perspective, that's my background. When you kind of encourage someone like you need to exercise, weight loss and all that stuff, neurologic adaptation, cardiovascular is usually within that first month. And then you start to be like, okay, I'm used to it, I'm acclimating, I'm adapting. And that's when you start to really, see those results. And I think that makes perfect sense the way you guys describe it.
Exactly. So that's why the time is very important. In one of the issues with certain publications is that they didn't take into account this essential factor. If you bring somebody for 1 week and then you take them down, you will say, no, you never adapt. It's awful and you're going to die. You feel awful. But if you actually bring somebody who's healthy, they bring it up here and they don't have anything, because sometimes, a lot of people, they don't know they have diseases until they start performing some exercise. And this is a special stimulus and a stress situation. So people then realize that they have like limitations. It's exactly the same that as what happens at high altitude. So a lot of people, they think they are healthy, and then when they come to high altitude, they feel bad. And when you actually go and perform a checkup on them, you will find something that they didn't know they had when they were at sea level.
Right.
Really good.
Oh.
That's a very good concept to keep in mind and as a basis, because just like you, I get calls from people from Florida or Texas, and they're coming up here. Like last week, a family is bringing up their 16-month-old baby that has a large ASD and pulmonic valvular stenosis. And the doctor down there said, no, you cannot travel. You cannot spend a week skiing in the mountains. That's going to be very bad for her. And they very carefully came up halfway to Colorado Springs with their 2 pulse oximeters, 2 different monitors. And then they very carefully came up, and after the first night, they called me, and they had oxygen, they had the pulse oximeters, she's acting perfectly normal. And nobody at sea level, the physicians do not have that concept. And I love that sentence in this article. What was it that said?
Comorbidities can always be discarded. Yeah.
Absolutely.
Yeah.
Absolutely.
As far as acute mountain sickness is concerned, they still could be at risk for a cardiac decompensation, but it's what you're saying. It's because there's an underlying factor.
Correct.
Absolutely. Absolutely. In fact, we wrote in a book that we published with my father that I'm going to show you right now. And it's called High Altitude. This is the book. High Altitude Pathology at 12,000 feet. There you are, me and my father. This was published in 1981. And let me tell you what it says in the introduction. It says, in fact, we consider the ascent to our city a test of cardiopulmonary fitness. So you see, it's a test. It's like running an exercise in a treadmill at sea level and suddenly finding that you were okay at rest, but then when you run, you had a coronary stenosis, and obviously you get short of breath and you get pain in your chest, that's angina, whatever. So when you come to high altitude, we're testing your system. And high altitude allows us, we run tests at our institution, and we do them fast track. And so we run all these tests, blood tests, urine tests, echocardiography, sometimes exercise stress tests and so on. And we come up with diagnosis that they had no idea that they had this disease or deficiency or insufficiency in some organ. Hypoxia allows us to test things that are normally not seen at sea level because they're on the top part of the oxygen dissociation curve. If you're on the plateau of the oxygen dissociation curve, you have a margin, you see, and the organism tolerates it. But when you come up to high altitude, you start going down the steep part.
So
And
the
then,
difference becomes bigger.
yeah, it becomes more significant. So
Mhm.
we're able to diagnose and tell them, oh, you have to look after this,
Yeah.
this, you get these treatments. And when they go back home, they feel even much better at sea level.
Yeah.
You have no idea how many people write to us and tell us, even after many years, I keep getting Christmas cards saying, oh my God, doctor, we're remembering you. Thank you so much. And, you know, and some people tell us
and plus-
sometimes,
And plus, they have the feeling that because they are coming to Bolivia and they get sick, they think, oh my God, you know, this is the worst nightmare situation you could get into, like getting sick
Right.
in a poor country.
right.
You know, what are you going to do? So actually they get really impressed by the fact that they could be treated better than at sea level, because out of the blue, we find out things they could never find out in places that were
And
lower.
it's a fact, dear Michael and Chris, nobody has ever died from an acute hypoxic condition such as high altitude pulmonary edema or high altitude cerebral edema with us in our institute.
Never.
Never. I mean, this is on record. I mean, you know, we couldn't hide it. We couldn't hide it if it had happened, you know. And we deal with insurance companies and so on. And the insurance companies actually look for us to treat their patients because they know we have had this fabulous response. I mean, you know, practically 100% cure from these diseases.
Yes. Mhm. And it's also important to think about chronic diseases that could be underlying diseases, but then also transitory diseases. For instance, somebody who comes and then they are climbing and they catch a cold, that person could have a high altitude pulmonary edema.
Right, yeah, cold exposure was a risk factor for sure.
Oh,
yeah.
have a cold.
Oh,
She means a
oh,
virus.
Oh, virus,
The,
yeah.
inflammation, the virus
Yeah.
triggers the decompensation.
Yeah,
Mhm.
yeah,
Because
exactly.
because this
Because
is
the
already,
virus is chewing on some tissues, you know, it has to reproduce itself in some tissues in your body.
yeah.
And if it takes some tissues near your lungs or in your lungs, then that you increase your blood pressure from pulmonary hypertension and hypoxia, and you break the capillary.
And you have
know,
inflammation, and you have
And-
a lot of disbalance in your body already. So
right? And so that's
so it adds up. You see?
when Andrew Pollard wrote Children at High Altitude, and you must have seen that, Chris, I suppose, we proposed that there was a viral cause of high altitude pulmonary edema, and it's
Mhm.
written there.
Yes.
And he understood that perfectly well. And in fact, it's written in this book, which we wrote in I even forgot when we wrote this, because we wrote it with my father.
Yeah.
This is in 1989. And in this book, look, we have high altitude pulmonary edema, 1989. And look at this tongue. This is the tongue. We love this tongue thing because it really helps us.
Well,
Look at this.
Yeah,
yeah.
that's interesting.
Yeah.
I had never heard of that.
Yeah.
So it's talking about the concomitant diseases, you know, that's the important factor. And it could be very mild diseases, and it could, but you look for an infection, viral or bacterial, even a urinary infection could be a problem. So because this person is already altered, then you have a lot of people who have traveler's diarrhea. They come here, they catch an infection, they get completely discompensated. These are the guys who will get the worst high altitude diseases. Always look for something.
Right. And if you treat the underlying cause, no problem.
They even climb higher.
Right.
12
right,
days after we treated them.
Right. That's a fact.
Pollard, Pollard.
Yes, Andrew Pollard, Children at High Altitude. It's the
Consensus.
consent. No, it was
Children consensus. I was
yeah, something like that. Children consensus at high altitude.
Mhm.
But it's very interesting, and that's why we wrote that paper that we're discussing now, because we had to show the world our experience, because what we read was not what we saw. You know, how we kept saying with Natalia, wait a minute, we need to write something and tell the story, because we have to give our experience, and that's exactly what we did.
And the thing is the focus, because many of the medications that are actually recommended to take are based on the idea that it's altitude that it's actually hurting you, while it's actually the change within one's body associated to some deficiency, basically. So, and the problem is that many of the articles that were talking about loss of adaptation, of this idea of that you get hurt by a high altitude, are based on PhDs projects. And now there's nothing absolutely wrong with being a PhD, because you can look into some research that you can't as a physician, but you've never treated one patient. So you are not aware of the other diseases that could be happening, because it's just, for medicine, you have to go years and years in your whole life studying. So you don't take in account something and then you think, okay, it might be the altitude, but they are just not looking at the diseases of the patients.
They're not looking at it globally. Mm-hmm. This is extremely important. You see, medicine is a beautiful, beautiful science, but it's a highly complex science. And people tend to make just some protocols and say, oh, you have to do this. No, every patient is a different patient. You have to.
We're just talking about how telehealth might lead to us being replaced by AI, because we're no longer looking in their ears and putting our stethoscope on their chest. So why couldn't computer just do this visit and make this diagnosis with their, let's move on to this leads us to the acetazolamide. Yeah. So we have like a flip here in our population. We have 30 to 40,000 people who live up here and are adapted. And then we have 1 million tourists a year who come up here from sea level for short periods of time. So I find Diamox is very useful and the side effects are very minimal. So I'm using it quite a bit. You're concerned but we do have local physicians who don't want to use it because of it could cause dehydration. What do you think is the mechanism of Diamox with acute mountain sickness, and what degree or what is the concern about dehydration? How severe is that?
Oh, very important. Dehydration is crucial. An extremely important high altitude factor. Yeah. Absolutely. Mm-hmm. Absolutely.
You can have even a stroke because of dehydration.
Right.
And there are even some studies that show that people that went to the highlands, they had strokes, but nowhere in the paper they show their dehydration parameters, and this is very important. I have done some studies. I did some publications about them that are short. Actually, I will do an extended study paper to show this. But at the hospital, I checked all the people who had strokes. If any of them had a higher hematocrit, because they are very much concerned by the fact that having higher red blood cells in the international publication would leave a higher, or will give a higher risk of clots and cardiac disease and all these things. And so I looked at these patients, all of these guys throughout 5 years, and all the records and everything. And I looked if they had a higher hemoglobin, and if they had other concomitant factors. Among all the guys who had this, I only found about 10% that had a higher hematocrit. And among these, absolutely all of them had comorbidities that we know are associated with strokes, particularly an increased hypertension. You would have some people who had diabetes, and then you would have dehydration. Very important factor. And at high altitude, when you have acute mountain sickness, dehydration is crucial. It's one of the very, very important reasons why these guys don't feel very well.
That's right.
Right. What kind of doses are we talking about of acetazolamide are you guys using over there? I think just like in my research and literature, it kind of indicates that like 250 to 500 is kind of adequate to treat
125,
Well,
we're only using 125, the idea.
Yeah,
Those keeps going
Yeah,
down.
I-
smaller and smaller.
yeah, so
Probably you would have to keep it this lowest possible,
Mhm.
really. But we don't use it much, to be honest. We have to be
Right.
honest. I mean,
We don't.
we don't, because
If it helps, I mean, I don't think there's any thing wrong with using it, but to tell you the truth, we don't. I mean, we find this a perfect opportunity to target what's wrong with the patient. Maybe acetazolamide can help you if you go up the mountain and you are, I mean, you don't have any medical facilities. I mean, you don't have much, can't really do much, nothing goes wrong, no? But if something goes wrong, then it's actually a great health test. So you just run the checkup and then heal the patient.
but of course, we are talking about our paper about people coming to high altitude cities where you have an institute like ours, which is, of course, ours is very unique because of all our experience and all that. But nobody should die from a high altitude disease in a city like the city of La Paz. But there is people that die because there, unfortunately, some other people, are careless. One day I get a call from the Chinese embassy, and I knew the ambassador. I'm always invited to the cocktails. Well, not lately.
Yeah.
Coronavirus, no cocktails for diplomats. Anyway, but often I am at these meetings, and we had met with my father, the ambassador of China. And one day he calls us up and says, "Oh, we just have a new accountant that has just arrived. A new accountant that has just arrived from China. He's a little bit overweight and he's not feeling so well." And so we said, "Well, send him over to our institute. We need to see him." That's the clue. Don't say, "Yeah, well, okay, we'll see it later." No, we say, send him over right now. And he said, "Oh, no, he prefers herbs, that he brought from China and so on. But and we have an oxygen concentrator or something like that." I remember that. Next day they call us. The guy passed away. And
Oh,
and
my
I
This
said,
is ridiculous. I mean,
but why did we told him, but we told you, bring him over. And he said, "Oh, no, he was, obviously people can die. But if you treat them and you know how to."
now, in regard to the acetazolamide, I think it's very important to also take in count that the psychological effect of learning that high altitude is going to harm you plays a huge impact. So if you have the feeling that you're taking something that is protecting you, believe it or not, you have placebo.
Yeah, absolutely. You feel safer.
Yeah, and we have seen this systematically with our symposiums. We like to bring people over to come with us, to go into conferences. We even travel with them. And how come every time they come to us, they don't get heavily sick? And that's because we give them the feeling that, don't worry, something would go wrong, we would treat you. We are highly trained for this. They come so relaxed, nothing happens to you. So if you at sea level bring this, give acetazolamide to somebody and tell him you're going to get protected by this, believe it or not, he will feel he's going to be okay. Of course, if something is very bad that he can't actually, adapt, it will come out. But most of the times, people are really scared of high altitude. And this adds up.
And if you're scared, the thing is, like, if you see a tiger, you immediately have tachycardia, okay? You have an adrenaline release in your body. So you start speeding up because you have to run, So that fear producing a liberation of catecholamines increases your heart rate. If you come to La Paz and suddenly you get off the plane and you start walking and you feel a little bit short of breath, which is absolutely normal, and you panic, you hyperventilate, you tachycardia, obviously you're going to get
overstressed.
Worse. But if you say, "Oh yeah, well, this pill's gonna keep you healthy, don't worry," then she's right. The psychology, maybe the most important psychological, the most important effect of acetazolamide is the psychological effect. And well, obviously there are some other effects that
unless it's
have
very
been
bad,
documented.
no?
There's many papers. I think there's thousands of papers many studies. We have also participated in acetazolamide studies here. I even remember from Stanford University. He was a medical student from Stanford University. He came to do some research with us, and he went and looked for all the tourists that are in the tourist area and asked them, are they taking acetazolamide or not, and all that. So we have a lot of experience with those things, but that's our experience, and that's how it goes.
So how many tourists,
Right.
do you have any idea of the number of tourists that come up to La Paz and El Alto on an annual basis?
I don't know for a
Yeah,
fact, but it's a lot. I mean,
right.
because also La Paz is the capital city of Bolivia. So whoever who may come to to the country comes generally to La Paz.
Yeah.
So
I have no idea, but maybe we can check it up.
mm,
You know, but it has to be a lot of people. I
Yeah.
mean, in the before COVID times, we had planes coming in all the time, people arriving.
And they come to La Paz,
because this
they go to the salt flats and the other tourist
Yeah,
attractions.
exactly.
So everyone goes
and
through.
also
Of
because
course,
of
some-
work, because of so many things,
Right.
because this is not a side activity. Coming to La Paz can be because you have to go somewhere else, or I don't know. It's a main city in Bolivia, so
Right.
mm.
Okay. What else is necessary?
All right. So I
Any
think
more questions, Michael?
Yeah, I got a few more, just maybe I think two more, and then we'll be done here. So I think at the end of your paper, you kind of addressed about how you
Right.
addressed about the fetal hemoglobin, how it has a very significant role in an organism's ability to survive later on. Could you tell us more about that? Or did you hear me? Oh no.
Did it freeze? We wore it out. Are you
I
there?
didn't, we don't,
I think we might have this. Yeah, can you hear us? Dr.
what's
Zubieta,
that?
Can you hear me?
Yes, I can hear you, but it wasn't very clear when you asked it.
Oh,
Yeah.
okay. So I think my question is,
Yeah, now I can.
okay, could you just elaborate more on the fetal hemoglobin's role in an organism's survivability, later in their life? I think you mentioned that towards the end of the paper, and I just wanted some more, just elaboration on that.
About the fetal hemoglobin, are you
Yeah,
saying, or
yeah,
the hemoglobin in general?
Yeah.
Fetal hemoglobin?
Yes, yeah.
I'm sorry, you're freezing.
about it-
You're
about-
freezing. I'm sorry. Okay, yeah. Okay. This is very interesting. For us, hemoglobin is the fundamental factor of adaptation in the Andes. Okay, let me tell you that I don't know if you have studied some of this, but anyway, babies have a higher hematocrit than the normal children at the beginning, and that is because they are living in their mother's womb at the pressure of Mount Everest. Okay, in other words, all of you 4 people there have already lived 9 months at the summit of Mount Everest, in your mother's womb. You were in a hypoxia with a PaO2 of 30 millimeters of mercury. We all have been. That's interesting. That's very interesting. And one of the factors was obviously we had the advantage of a fetal hemoglobin. But of course, as you know, when you're born, that fetal hemoglobin goes away. And but you have tolerated these hypoxic levels perfectly well. And that's what made my father think that, my God, at that point, and also that when we see patients with chronic mountain sickness, they sometimes come to our consultation, and these guys have a hematocrit of 75%. Now that's very high, but they come into our consultation and we run blood gases, and sometimes we have measured even 26 millimeters of mercury in arterial blood gases. And when we first saw that, we said, uh-oh, the machine's not working. Something is wrong here. A new recalibrate, new sample, run it again, and it was 26 or 30. And so that's when he wrote the triple hypoxia syndrome. And that's a different point that we're writing some other stuff about that, but it has to do with three types of hypoxia being added in these patients at high altitude. The first one is high altitude hypoxia that we all have right now.
Hypobaric.
Hypobaric hypoxia. The second one is the lung disease or heart disease hypoxia, because there's a deficiency in lung. And
COPD, for instance.
yeah, and the third hypoxia is a superimposed hypoxia due to perhaps a pneumonia, or maybe a pulmonary thromboembolism. So your third hypoxia is the third more hypoxia that's adding up. So these guys come in, but I'm not saying these guys are coming in with a pulmonary embolism, but I'm saying that these guys come in with a cold or something like that, and you measure their PaO2, and they are guys that say, well, how are you feeling? We ask them, and they say, well, I'm not feeling so well. But these guys are walking around, and they're having a normal life. And you ask them, have you been working? Oh yeah, today I was at work. Yeah, okay. But I'm not feeling so well. But so that's when my father said, oh, wait a minute, these guys are right now living at the summit of Mount Everest. So we treat them. We give them oxygen, and we give them antibiotics, depending on what they actually have. And then in a couple of days, they're back to their normal second hypoxia, which is their lung disease basics. And so their oxygen has already improved within a couple of days normally. And so that way, he proposed that man has already lived in the womb on the summit of Mount Everest. But now these guys are also coming back to live, they go back to living at the summit of Mount Everest because of their lung disease. And the only factor that's allowing them to live that high is the increase of red blood cells. And so that's why he proposed men can adapt even to the hypoxic levels of Mount Everest. Now that has shaken the physiology, high altitude physiology. And many sea-level physiologists were really upset with my father.
Because
Why?
they think it's impossible. I mean,
they think it's impossible because they had looked at populations all around the world, and they found that 5,000 meters was the altitude where there were populations. And so they said, oh, that's the limit of human survival at high altitude. And they did it based on that observation. But they forgot some important factors which my father mentioned. In the womb, you'd not only have more red blood cells, you not only have the hemoglobin, fetal hemoglobin, you also have a beautiful temperature. Whereas in the summit of Mount Everest, you are freezing, you have been climbing during so many days.
You may not be hydrated.
You're not well
not
hydrated.
eating.
You're not eating. You're so cold. You don't sleep.
Right.
And it's horrible. So how can they do well? But in spite of that, people went up to the summit of Mount Everest without oxygen. Messner and Haveler were the first ones, and they made it to the summit of Mount Everest. Many top sea-level physiologists had made calculations and said it's impossible for man to stand on top of Mount Everest without oxygen. I'm sorry, but not true. Now even a woman has gone up recently, or maybe more than one, to the summit of Mount Everest without oxygen. Why? Because with more red blood cells, you're able to tolerate severe hypoxia.
Yeah. And the thing about the red blood cells is that people are afraid that if you have more red blood cells, you would have this clotting and in these things. But they don't take in count that when you have a higher level of erythropoietin, you also have a higher vasodilation.
Right, yeah.
And you also have even angiogenesis.
Right.
And so if you have more routes for people to move around, then you don't have traffic. It's exactly the same that happens with red blood cells. Now, these guys, you will look at them, and these guys who are very hypoxic because they have so many diseases and stuff, and they live here and everything, and they can be blue, when you look at them, they are purplish bluish.
Cyanotic.
They have an extreme capillarity. It's just like when you have, like your lips, the color of your lips is associated to the capillaries. So if you have this all over your body, then you become more bluish, you know,
Right.
more purplish, more or less, no, because they are also hypoxic. But that's because they have several things adding up, and
Yeah.
they compensate. They really do. Now, if you have a deteriorating disease, because let's say you have heart disease, have COPD, then your lifespan can also be shorter, but that's because you're sick, you know. It's not because of the red blood
It's a
cells.
pathology, right?
Exactly.
Right.
Or cancer.
Or, yeah, or whatever,
What about
maybe, no?
anemia, like sickle cell, anything like that? Have you guys, has there been like higher incidence of like a acute incidence of in patients with anemia? Have you guys noticed anything like that?
I could say that, for instance, people who have been vegetarians,
Yeah.
they can have a higher risk when they come here because of anemia.
Oh, yeah.
And you have young people and have people who are apparently very, very healthy, but they come and they don't, and they come in groups and everybody's doing fine except them.
If you don't achieve, Michael, the adequate red blood cells your body needs to compensate for a low barometric pressure, you are not doing an optimal adaptation to high altitude. So you have to have enough red blood cells. Now, unfortunately, sea-level physicians think that normal red blood cells is only that found at sea level. That's not true. My hematocrit is 50%. My hemoglobin is 16 grams %. 57 years here at high altitude with those red blood cells. Believe me, I love my red blood cells, my extra millions red blood cells, because I have a beautiful life. I can do sports, I sleep well. I'm not overweight, by the way. You know, we tend to have less overweight problems here than at sea level.
Except if you have a bad diet and stuff. No?
Right,
Because,
right.
I mean,
But the quantity of overweight, if you see it, it's much less than, we don't have these severely obese people here. Very rarely we have somebody. And when I see one in the street, I can always say, oh, this guy has come from sea level. And mostly, in fact, at one time in many years back, we had a company from the US come with a specialist, and they said, we're thinking about bringing people to La Paz, Bolivia, and we would like to know if your institute can support us. We want to bring very obese people to high altitude, which was not a good idea also, you know, because obviously you're going to have complications from having somebody very obese coming to high altitude.
and who has metabolic syndrome and all these things, you know, this is not a normal person.
Right, there's sick people.
So I think my last question here is, so what other, what are your future plans, just kind of moving forward? You guys have any other projects that you'd like to share with us today?
Ooh,
yeah.
Lots of cool stuff is coming. Get ready for some real hot stuff coming. I tell you, it's coming. You're going to love it, Chris. You're going to love it. We have several papers are lined up, and they carry exactly the same spirit you saw in that paper that we're discussing. It's our experience. It's our confidence in what we're doing. We have absolute confidence in medical care at high altitude because we have experience, we know. And so, we have several very interesting papers coming up. You'll have to see them. You'll have to see them when you see them. They're well developed. One of them, by the way, has to do with...
Give us one, yeah.
Topics, yeah.
Okay, one that's almost out is a much lower case fatality rate at high altitude due to COVID.
In the Andean region.
What I had told them I had told the world from the very beginning that the people at high altitude would not have that serious effect of COVID as at sea level. I had put that forth based on my experience, almost intuitively.
Yeah,
okay?
But based on the first statistics we could find. But of course, we didn't know what would happen. I mean, it was risky.
but I launched that in February of 2020 before COVID arrived to La Paz.
Yes.
Okay, because it arrived in March. And I even wrote a press article saying that we are going to be protected by high altitude. And that is becoming an absolute reality. Wait till you see this next paper coming up, Michael.
Because we did the follow-up throughout the whole year in different countries and everything.
We have 5 countries. We have a team of over
Maybe 20 people.
25 people
Yeah.
have been working for the past 6 months, getting data from all these places. And it all lines up to tell us you're right, which I love.
That doesn't mean that we are protected fully, you know, of course. I mean, you have to take protection.
Of course, there's
measures
death.
anyway.
You
But
have to have,
if you compare it statistically, we have less.
Right.
right.
Yeah.
Mhm.
I think I remember briefly reading about
Yeah.
this paper. You guys had mentioned that, like, you know, because of COVID-19, you guys were going to see less rates of, you know, deaths due to hypoxia and what have you. So, no, I look forward to that. You guys have any more questions? I think we're all set here.
Well, that was great.
Yeah, yeah.
Thank you so much for spending this time with us. It's so good to be together again. I can't wait until we can just meet and give each other a hug and
Good to see you, Chris.
Yes.
Good to see you. And I'm happy you have all your students. They're learning so much from you.
Mhm.
And I believe that we may have contributed with a little bit with a different concept
Yeah.
of life at high altitude and how we handle things. And I hope it's useful for them.
Yeah. Trust your know-how, you know, in the sense of looking into in depth, like what's happening with each patient. And if you have any questions or I don't know, there's always something that one can learn and discuss. So
Yeah, we're always here. We love this, but truly,
Yes.
this was one of our good interviews. By the way, I'm being invited to give talks all over the world now, and it's actually kind of driving me crazy because it's talks here and there and everywhere. And we're looking into many aspects. One of my last talks had to do with the effects of ultraviolet radiation. And we have some information about that coming up too. You'll see some of that.
yes.
Yeah, don't be afraid to send that information my way. I have your info now. So,
Sure.
yeah, appreciate it. Yeah, appreciate your time today. Thank you so much.
good night.
Take care.
Yeah,
Bye,
happy.
Chris.
Take care.
Bye,
All the
Michael. Bye,
best.
bye.
Have a
Nice
wonderful
meeting
evening.
you all.
Nice to meet you.
Don't forget to send us the recording.
Please,
I
please
will.
do.
Oh, yeah. The file might be a little big. It's an hour recording, but I'll find a way to get it to you.
Yeah,
Yeah, no problem.
it was long, but I hope you enjoyed it.
Take care. Bye-bye.
Yeah, bye.
Have a wonderful. Bye-bye.
Bye. Okay,